please, sign up for CME. For grand rounds, you have the information up front, and Susie will send it around on text about halfway through, as she always does, and thanks, Susie, for that. I want to also remind folks that next week we have a faculty meeting, and then after that, we have a few, we have some fellows presenting, and then we have the American College of Cardiology and a break before the next faculty meeting. So, Dr. Spertus here is going to, give us a treat today and teach us all about PROs, and I'm excited to learn a lot. And before I get him up here, I'd like to just ask Harlan to come and introduce them. They've been long-term friends, and I know have built
Where's the CV?
the outcomes, right? The CV is like this big. So.
Oh, God, it's too big. It's my great pleasure to be the one to introduce Dr. John Spertus. So one of the great things about academia, and is in the course of your careers, you get a chance to meet people who become lifelong friends, and some of them become your best friends. And that's been my privilege with John. And from the moment I met him when he was actually a fellow, I realized that, gosh, this guy has got the most amazing range of ideas. He's one of the more creative people I've ever met. And I thought, like, I got to get to know this guy. I mean, he's at the University of Washington. He's like a research fellow finishing his cardiology fellowship. And I'm going like, wow, I've rarely encountered someone who's so generative and so thoughtful. What I didn't know at that time was also how generous he is, what a wonderful individual that he is. And as I've seen the degree to which he's been able to contribute to the careers of so many people. And it really is one of the essences of being in academia is that you have a chance to touch so many people's lives. And John has done that so effectively and helped to guide so many different people that's almost overshadowed, honestly, a lot of the other accomplishments that he's had. But he has had substantial accomplishments. And I'm not sure that I know a handful of more people who've had greater impact on the practice of medicine that John has. And he's done it in a very interesting way. I mean, his interests are wide-ranging, and I will not be able to go into all of them, or I'd take the whole grand rounds on that. But I just want to take 1 second to say that there have been a lot of people who have been interested in promoting patient centricity in medicine. So, as physicians, sometimes we're socialized into thinking about our own world so much that we get on a conveyor belt as we think about patients. And it can become very transactional. And the patient voice, their ability to sort of channel their perspective can become muted within our day-to-day rushing around. And in our studies, we can study outcomes, but we can miss what's often most important to patients, which is how they feel, the symptoms that they have, and the weight on them. John approaches in an extraordinarily scientific way. So there's lots of people who cheerlead about this. People give talks about, we've got to pay more attention to patients. We have to do this. But I will say, without structural change, without the actual tools to make this happen, without creating assays that enable us to, with precision, accuracy, according to psychometric principles, be able to use these tests to evaluate how people feel, we would be in the wilderness about this. We wouldn't be able to use them in our studies, and they wouldn't be reliable in practice. And we'd be left like we are usually, which is I can ask somebody some questions, you can ask somebody some questions, and when you look in the chart, you can't actually compare it because there's no standardization across it. John is the leading expert in the introduction of these tools into cardiology, which have transformed them all. Take a look at any clinical trial, take any heart failure trial. They're using his instruments, his assays, and it's not just, I'm not just celebrating John in this place. I'm saying he has enabled those trials to use the patient's experience to be the fundamental barometer of whether or not the interventions have made a difference. And he continues in that realm and a whole other set of realms of important and whole same as cardiology. But I challenge you to think that there are areas that you're interested in to be thinking about the kind of journey that John's been on and the kind of impact that he's made by creating tools that enables other people to excel and to bring that patient voice forward. So it's with great pleasure. I introduced John because otherwise I'll just spend the whole time talking about you. But thank you for joining us today.
Well, thank you very much. I mean, what a terrific introduction. Just for, there are not a lot of residents, it doesn't look like, that are here in the audience. But I will let you know that the first time I met Harlan, I was a cardiology fellow in Seattle, and he was giving, they used to have oral abstract. He was giving an oral abstract on some of his very early sort of work trying to understand myocardial infarction from the NeuroMe database. And I went up and I talked to him and, engaged, I had some trivial, completely irrelevant, flaw in his methodology or something like that. But, it was so exciting to have somebody who was really interested and intellectually stimulating. And I have been back, a couple of times to Yale and watched him grow. And I mean, nobody has sort of grown and made quite the impact he does. But I want to say that what's been particularly gratifying in this particular visit is to see a lot of the trainees, Nihar, Jephthah, Erica, others who he has inspired who are now leading this division. And I'm just so bullish. Eric and I were talking about how things are evolving. It's very, very exciting. And so one of the joys of academia, assuming you live long enough and don't shift to industry, is to be able to watch this evolution, growth, and impact. As Harlan noted, I've been very interested in trying to measure and quantify patient symptoms, function, quality of life. And I could give, a lot of talks on the science of how you do that, how you could use these in clinical trials, how you can interpret them. And I really want to deviate from that. I mean, I think just take for granted these things are good tools. I'll give you a very high-level overview for them. But I want to stimulate and excite you to think about all of a sudden, if you have the ability to quantify the patient's experience, how could you leverage that to deliver better, higher value, more patient-centered care? These are my disclosures. And the principal one is that I've spent my entire career working on trying to develop these measures. They're copyrighted. I license them. They're very inexpensive, except for industry, but they have allowed us to continue to grow and evolve and build the science that I hope to share with you today. And, I know that I'm a little geeky, and I'm going to make that really clear in the next couple of slides. But, just imagine that you had a test that, could define the status of a medical condition with greater accuracy and actually greater clinical efficiency than the way it's currently done. That it could risk stratify patients' prognosis, that can identify with great accuracy who's going to benefit from treatment and who may not benefit or be harmed. That it could help monitor the response to therapy so you could titrate up or down therapy to optimize how the patient's health is doing, that it could support population health management, and that it could even define the quality of care. And obviously, I'm not talking about a tricorder. Give it all the prelude. I'm really talking about patient-reported outcomes. And I really want to sort of walk through how I think these could be done after a very brief review of what these are. So if you think about coronary disease, there's a conceptual model where there's an underlying pathophysiology, whether it's atherosclerotic coronary occlusion, microvascular disease, inflammation. Patients are not going to be aware of how narrow their coronary artery is, but they will be aware of the symptoms of angina, how that angina can impact their physical, emotional, or social functioning. And to the extent that they're living differently than they would like to live, their quality of life may vary a lot. So I like to take a prototypical example of a 42-year-old construction worker who gets angina once or twice a week, climbing a couple flights of stairs. And if she cannot work as a construction worker and none of her friends have angina, her quality of life might be terrible. But the exact same angina once or twice a week, climbing a flight of stairs for a 72-year-old widower may be no big deal because he's doing better than everybody else he knows, and his quality of life might be great. Independently capturing these characteristics so that they can be actionable and understood is the way we thought about designing these PROs. And I think all of them are really trying to understand how the disease, as opposed to our approach about thinking about the physiology and anatomy, how patients experience their disease so that we can measure that. And I'm not going to go through the psychometric properties, as I said, but all of these tools have gone through rigorous demonstration that they're valid, that they're reproducible and stable patients, they're sensitive to change. We've created thresholds to understand what's a small, moderate, or large change. And then just translating them is a very lengthy, expensive, and arduous process. And so I'm really going to go back and forth between two examples. One is the Seattle Antigen Questionnaire. It was originally 19 questions. To make it feasible for clinical use, it's been reduced to 7. And what it does is it asks those kinds of questions that a clinician would ask in a routine clinical visit. And so we ask about how limited they are due to angina, how often they have it, has it changed, and are they satisfied with their current treatment? And you can create a SAC summary score. These scores range from 0 to 100. The higher, the less symptoms, the less physical limitations you have, the higher your quality of life. They've got very good psychometric properties. They're in about 70 languages now, and they're associated with other clinical outcomes. And importantly, these domains map exactly to those concepts that I talked about when I laid out sort of how we want to think about health status. And these things often sound a little amorphous, like the SAC, the KCU. What does that actually mean? I mean, let me just walk you through how simple this is, right? So this is the 7-item SAC. And what does it do? It basically asks on the physical limitation scale, are you limited because of your angina in walking indoors on a level ground, gardening, vacuuming, or carrying groceries, or lifting or moving heavy objects? Different exertional requirements to try and capture it. And this is basically exactly what a clinician would ask a patient in a clinic visit, but it asks it exactly the same way every single time. And I know that when I start my day on Monday, I get a much better history than I do Thursday when I'm hours and hours behind on notes and I'm an hour late in clinic and the nurse keeps knocking on the door that the next patient's waiting. You just don't take a history. Here, you're getting it every time exactly the same way. How often are you having angina or do you take nitroglycerin? That's all the angina frequency scale is. I mean, it's not rocket science. If you had to live this way the rest of your life, how would you feel about that? These are the kinds of questions that I think make a good standardized history. The KCQ, same concept. There's a symptom scale that gets severity and frequency. There's a summary score meant to replicate the New York Heart Classification from the patient's perspective. And then there's an overall summary score that seeks to integrate all of the patient's health status. It too is just it's now in about 125 languages, a lot of good psychometric properties. But interestingly, it's been qualified by the FDA, both the drug and the device side, as a potential approvable clinical outcome in clinical trials. And that's led to a marked expansion of its use in drug and device trials because now you could actually get something approved if it makes patients feel better and improves their function as assessed from their own perspective through the KCCQ. And I'm not going to go into it, but that took on the device side, it went pretty quickly, but on the drug side, it took about 4.5 to 5 years, over 5,000 pages of documentation before they finally qualified it. And I gave all the data for the 12 and the 23-item version, and they only qualified the 23, and they only qualified the clinical summary symptom, total symptom, and physical function scale, but the device side approved all the scales. And again, it just maps to the same underlying constructs. So let me now that you have a little background, let me tell you about how I think this could be used. And so first, defining the status of a patient's medical condition. When I was at UCSF in medical school, as a medical student, we rounded at the VA. And a lot of the veterans had, rheumatic heart disease, et cetera. And these clinicians would come in, we'd percuss the heart, they'd feel for thrills, we'd auscultate, and they would define for us, based on their physical exam, what the anatomy and physiology of the heart was. And, basically, we all listened. We didn't hear the same thing. So who was right about that? Well, it was the doctor with the most gray hair, right? I mean, so there were obviously variations in the accuracy and reproducibility of understanding the anatomy and physiology. And then along comes the echocardiogram, and everything gets very standardized very quickly. Well, when you think about the gold standard of understanding the symptoms and impact of a patient's disease on their health status, what's the gold standard? It's the history of the individual physician. That's also going to lead to lots of variability in the accuracy and reproducibility of understanding the symptoms and the function of the patients. And I think that's going to evolve into using these kinds of standardized PROs. And, what are the PROs? I mean, as I've sort of laid out, it's about trying to hear the patient's voice. And that's what we're really trying to glean from this. And so the question is, how accurately do physicians assess angina? So we partnered with the ACC and we did a 24-center study where we asked each center, the next 25 patients that come through your clinic with coronary disease, we would like for you to have them fill out the SAC. And the idea was that the patient is telling the doctor how much angina they have. These are cardiologists, by the way. This is not, you'll see some data in primary care at the end of this talk, but these are people whose job it is to assess their angina, right? And so we would figure out from the patients how much angina they had by asking them to fill out the SAC. Then the doctor, hearing that, would assess their angina by a report blinded to what the patient filled out on the SAC. And we looked at the concordance between the two. So in this almost 1,300 patients, 2/3 had no angina, which, you would expect in a cardiology clinic. About a quarter had monthly angina, and about 8% had daily or weekly angina. And if you look at those who had daily or weekly angina, 2/3 of the time the doctor got it right, but a quarter of the time the doctor said they had no angina at all. Patients saying, I have angina several times a day to a couple times a week. Doctor says they have no angina. And, the concordance between the two was about 0.48. That's the kappa. And, we thought, well, this is really interesting. I am sure that women are being under-recognized compared to men. Blacks less than whites, older people less than younger people. And we looked at what predicted the under-recognition of patients' angina. And it turned out essentially none of these things predicted angina. The strongest thing associated with under-recognizing angina was the doctor who saw the patient, with almost a 3-fold median odds ratio, meaning that one statistically identical patient going to one random doctor in our cohort versus another random doctor in a cohort had a 2.5-fold greater likelihood of being under-recognized at one of those doctors' visits. And when you look at the doctors who saw 10 or more patients, the variability in under-recognition went from me at 1, which was 0, to a doctor 15, 84% of the time, he under-recognized this patient's angina. I mean, this is the kind of variability. And then it turns out, I mean, this is no shocker, that the strongest predictor of not escalating treatment, referring to the cath lab, getting another diagnostic test, increasing anti-anginal therapy, was under-recognizing the angina, because of course you're not going to further treat the patient if you don't think they have angina to begin with. Right? So to me, there's a real consequence of this. And so could this be improved by having access to a patient-reported outcome? And so Alex Sandu's K Award was on implementing the KCCQ into clinical practice at Stanford. And, this was a randomized control trial where the patients, all the patients got a baseline and a 1-year KCCQ, and then the patients who were in the intervention arm, their doctors got to see their KCCQ scores. And so he looked at, is there less variability in assigning New York Heart when the doctor actually got to look at the KCCQ score of their patients? And that's what he's showing here. And so to just highlight, look at the patients where the doctor assigned a New York Heart Class 3. In the dashed line is the reported KCCQ scores of patients in whom the doctor uh, thought they had class 3. And I don't know if I could do this, but what you see is that there are patients with scores of 90 and 100 that the doctors called class 3. There are patients with scores of 0 the doctor called class 3. But in the patients where the doctor saw the KCCQs before they evaluated the patient, there's much less variability in the self-reported health status of the patient. Again, evidence that sharing the reports from the patients will improve the accuracy with which the doctor makes the diagnosis. This will come up later, but the other thing that happens is that it makes your visit a lot more efficient. So when you walk into the room and you know that the patient has a score of 100 and it hasn't changed from the last time, your visit, your way of thinking about that patient is going to be a lot different than if you walk in and their score is 40 and last time it was 100. Because then they're doing a whole lot worse, and you're going to really not talk as much about their kids and how they're doing and how the graduation was the last time you saw, but you're going to figure out, looks like you're not doing as well. Can you tell me more about it? That efficiency is also can be very helpful and often outweighs the extra click it takes to pull up the KCCQ scores in the EMR to look at them. Risk stratifying prognosis, again, this is not particularly novel because the sicker you are, the more likely you are to die or be hospitalized. And so the KCCQ, this was the first cross-sectional study. Harlan, I think, was on this paper looking at the KCCQ scores in Ephesus and looking at how it risk stratified prognosis such that patients with a score of 75 to 100 at a year, about 10% had either died or been hospitalized, as compared in red with those having a score less than 25 and half had been hospitalized or died within 6 months. When you look at a fully adjusted model for predicting 1-year death and hospitalization, the strongest predictor is the KCCQ scores of patients. Mikhail Kosoboro, who trained here, looked at change in score. So that's a cross-sectional KCCQ assessment. What about change in KCCQ? Is that associated? So if they get better, are they less likely to die or be hospitalized? If they get worse, are they more likely to die or be hospitalized? And this is a fully adjusted model for over 25 characteristics, looking at the 3-month change. And what you see is for about every 5-point change in the KCCQ, if it increases by 5 points, their hazard ratio is about 10% lower for dying or being hospitalized. But if it gets worse by 5 points, then it goes up by 10%. And so what should you pay attention to? The cross-sectional score, the change of score. So we, looked at that, right? If you see a patient today and they had a prior score, do you pay attention to their last score? The couple slides ago I showed you. Do you pay attention to this score? Do you pay attention to the change in scores, right? What's most important? And does it matter if they have HFrEF or HFpEF? And so we did an analysis in the TopCat and the HF Action trial, trying to understand what's the impact of cross-sectional and serial KCCQ assessments in estimating prognosis. And, this is a complex side, and Harlan's going to be upset that I don't just have a picture and just talk about it. But the idea is that it turns out in both an adjusted and unadjusted analyses, looking at the previous score, that there's almost no difference in the hazard ratios, and it doesn't matter if they have HFpEF or HFrEF. And so what this says to me is that the KCCQ is getting something different. It's not associated with age. It's not associated with diabetes. It's not associated with a lot of other sociodemographic and comorbidities, because if it was just a marker for that, then the adjusted and unadjusted rates would be completely different. And so it's different. And what you see is that the adjusted current, change, and past KCCQs are all independently associated with patients' prognosis. However, when you include past and current or change in current, it is only the current assessment that is prognostic and the other one washes away. And so what you really have when you're serially collecting the KCQ is a consecutively and serially updating estimate of the prognosis of those patients. And so that is, I think, a very valuable tool in trying to understand the prognosis of the patients you're seeing in routine clinic. Now, what about identifying which patients benefit most from treatment? So when we're thinking about coronary disease, we're either trying to make patients live longer by preventing deaths, MIs, heart failure, or we're trying to make them feel better by improving their symptoms, function, and quality of life. And, frankly, if you ask patients, and we've done this, the latter they care often more about than the former. And so, obviously, I think everybody here has heard of the ischemia trial. It showed absolutely no difference in clinical events over 5 years, but it did show a significant improvement in quality of life. And so the question is, how do we interpret, how do we think about sort of these kinds of data in incorporating it into our clinical practice? So as a reminder, the ischemia trial was based on randomizing patients who had a high risk stress test. And so they at the site, they had a high risk stress test. It ultimately got overread by a core lab. So there was inaccuracy in the stress test results. And then they were randomized to go to the cath lab, get whatever they needed for revascularization, PCI, CABG, and optimal medical therapy, or they went to medical therapy alone, and they were followed for both a 5-composite clinical outcome of death, MI, unstable angina, heart failure hospitalization, and sudden cardiac death, as well as their symptoms and quality of life. And when we look at the clinical outcomes, is there any variable here that would help you decide, is this patient more likely to benefit from going to the cath lab versus being managed medically? So, a lot of the risk stratification we do is to identify those we should treat differently. And in all the analyses, the subgroups, we do not see any evidence of heterogeneity of treatment benefit, meaning that none of these parameters would help us figure out this patient is going to be better treated and have better outcomes going to the cath lab or being managed conservatively. And, the entire ischemia trial was predicated on the existing literature that said that the greater the burden of ischemia, the more you benefited from coronary revascularization. But when we look at those patients who had no or mild ischemia, moderate or severe ischemia, there was no heterogeneity of treatment benefit. In fact, in this trial, where all of these centers were supposed to be experts at doing non-invasive imaging, the difference in the occurrence of a 5-component clinical endpoint did not differ if you had no or mild ischemia, if you had moderate, or if you had severe ischemia. It didn't even risk stratify prognosis in the patients treated medically. I mean, this is really astonishing. And so you want to figure out who to send to the cath lab. None of these things will help. In contrast, if you look at the percent of patients who are angina-free by the baseline SAC angina frequency score at 3 months, what you see is that if the patient has weekly angina, they have about a 15% chance of being angina-free with medicines alone. They have about a 45% chance of being angina-free if they go to the cath lab. That difference in absolute risks between the two is so great that for every 3 patients you send to the cath lab with weekly angina, 1 is going to be angina-free at 3 months than if you manage them conservatively. Conversely, if the patient has no angina at baseline, there is no difference, and the number needed to treat is infinity. This is an example of the heterogeneity of treatment benefit but it's not based on a biological or a physiologic marker. It's based on the patient's baseline health status and angina frequency. And it holds out to 12 and 36 months. And so while we used to believe that the best way to risk stratify patients to who should go to the cath lab and who not was a nuclear stress test, I would argue it's actually probably a 7-item Seattle Angina questionnaire. And, you know, the importance, the concept of this of really trying to figure out and engage patients has really been highlighted in the adoption of the ischemia results into the updated guidelines, where the number 2 take-home point was that treatment decisions should be patient-centered, incorporate patient preferences and goals, and include shared decision-making. And, you know, when we conducted this trial, you know, like every other trial, we, you know, basically worked hard for 7 years. We had late-breaking clinical trials at the AHA. We had simultaneously publications in the New England Journal, even got accepted the guidelines. And yet nothing really happens, right? And so I'm going to summarize the outcome of a major effort we made that I think should model how all clinical trials ought to operate from now on. And the steps we took is that we had a series of focus groups with patients and their caregivers to ask them, what's the most important outcomes to you if you're, because these were all patients who had coronary disease, if you're deciding between going to the cath lab or not. And it turned out death was most important, followed very closely by quality of life, followed by physical function, followed by angina, then MI, and then way later was like peri-procedural complications, et cetera, et cetera, et cetera. So we learned from patients what was most important. We then modeled, so we leveraged the 5,200 patients from ischemia to predict those outcomes they valued most. We created this risk model of the heterogeneity of treatment benefit. Then we worked with patients and say, how could we present this information that would make the most sense? How could you best understand it? So we had a series of focus groups. And so we did all of that. And then we created a website that will allow you in a clinic to be able to enter the 8 variables that run the whole model, and then to generate this 1-page shared decision-making form with your patients that looks something like this. There's a very, very brief description. What is coronary disease? How, you know, might that coronary disease be treated? And then, you know, what are the 4-year survival, which never differs if you go to the cath lab or not? And then given on the left, what your, you know, this is sort of an extreme, but somebody has terrible quality of life. How's your quality of life going to be not going to the cath lab or going to the cath lab? What's going to happen to your physical function or to your angina? There are small differences in these estimates. And so the patient can say, is it worth the hassle and expense going to the cath lab for these benefits or not? What this is, I think, is transformational, because this is taking the data from a major randomized clinical trial and allowing it to be customized to the individual patient rather than just summarizing broadly, oh, you know, people have better quality of life because you have a lot of angina, go to the cath lab. You know, here, the patient can see how people like them, their age, their diabetes, their degree of ischemia, how they're likely to do if they choose an invasive or not. Every clinical trial, in my mind, that the NIH or that industry invested ought to be thinking about how they're going to translate those results to future care, so we don't have this 17-year gap between the availability of data and its use in clinical practice. And now it's actually called ischemiariskcalculator.org, but it's now available on the web and you can use it. So what about thinking about how other ways you could use this in clinical care? So, you know, I think this could be used in treatment. This has not been proven, but, you know, just conjecturing here, you know, we have lots of new treatments for patients with heart failure, and they all have generally similar relative risk reductions in death, hospitalizations. And so why not predicate it on quality of life? Why not test it in a patient? So you have a patient, give them a KCCQ, have them come back in 2 months and repeat the KCCQ. And if the patient improves, you continue treating them. If they, and the other thing is that the patient, if they do improve, they know why you've added this new medicine. They've seen data that they're doing better. They're likely to stay much more adherent. And obviously, you don't get the benefits from treatment if you don't take it. So here's a way of thinking about engaging patients and better understanding why we're recommending a treatment and to work with them to monitor their response. It's like an N-of-1 trial. All right, it's not double-blinded, but it's still, I think, very novel. And if they don't get better, maybe try something else. And so simplistically, you've got an outpatient with stable heart failure, you get your baseline score, you then make your treatment change, and then you follow them up. And if they're 5 or more points better, keep it going. If they're not, then try something new. Now maybe there's other reasons, there's such compelling data that, there's a survival advantage, even if it doesn't improve quality of life, so be it. But just explain that to patients so they understand it. And, these are ways I think we ought to be thinking about leveraging the patient voice to tailor treatment to optimize the goals they care about. I love this idea, right? So in, our entire healthcare infrastructure got completely upended with COVID-19, right? And, we went overnight to telehealth, right? You did it, we did it, everybody did it. We reported sort of what happened at St. Luke's Mid-America Heart Institute. And, what you see here is in 2018 and 19, 100% of our visits were inpatient. And in 2020, 88% were telehealth visits. Now, that's not that remarkable. And so when you look on the right at office versus virtual visits, these are the numbers, they're all office visits. Then we completely invert on a dime. And then we lift the sanctions for, quarantining. And, all of a sudden when the shutdown ended, we went right back to office visits. And now about 98% of our visits are in person. Does that make sense? What if you could think about now getting your KCCQs, and then before the patient comes in, you get them to do it online, and they have not gotten any worse since you last saw them. Their KCCQ is greater than -5 points. Why not do a telehealth visit? It's easier for the patient. It's easier for you. Now, I know there's dysfunctionalities in reimbursement that may preclude that, but still, especially if you're in a Medicare Advantage program and you're sharing risk with the payer, I mean, why not? And obviously, if they're getting worse, bring them in for a more careful evaluation. I mean, this isn't rocket science. It seems to me, though, we're not leveraging these opportunities to better track our patients at a population health level to do it. I talked about the limited value of an invasive management strategy in asymptomatic patients. And I believe that's true. But I'm not anti-interventional cardiology. And so, we need to think differently about how to identify those patients who need invasive management. I used to say, I think we're probably doing exactly, when we were working on the appropriate use criteria, we're probably doing the exact right amount of angioplasty in this country. We're just doing it in all the wrong people. How do you find the right people? Well, John Beltrami led this study about a decade, maybe 2 decades ago now, 15 years ago, where what they did is they surveyed 207 primary care GP practices in Australia. So throughout all of Australia, and they asked the docs for the next 10 to 15 patients who come through, give them the SAC. And then they categorized it in daily, weekly, or angina. And then we sought to describe in a primary care practice, what percent of the ischemic heart disease patients have daily or weekly angina. And this is what we found, right? There are practices where none of their patients had daily or weekly angina. But for about a fifth of the practices, over half their patients had daily or weekly angina. Have they even seen a cardiologist in the last 1 or 5 years? Probably not. So the opportunity to think about leveraging PROs as the infrastructure for understanding how patients are doing, it's amazing. Same thing, you guys are developing unbelievable algorithms for diagnosing hypertrophic cardiomyopathy. You probably can pull the database and get, hundreds of patients with super thick valves considered hypertrophic. They're probably patients with that in their discharge diagnosis. Now we have cardiac myosin inhibitors. Why don't you send a KCCQ to all of them and find those that are doing poorly? I think these strategies, in our clinic, we've been collecting the SAC in all of our nuclear stress tests for coronary disease. What do you do in people, largely middle-aged women, who report 60 SAC angina frequency scores less than 60? They say, I have daily and weekly angina, and there's no epicardial coronary ischemia. We're now starting to think about referring them for microvascular angina assessment, because it takes about 18 to 24 months to diagnose microvascular coronary disease after 18 clinic visits and tests. How come we can't accelerate that by leveraging the insights from these descriptions of patient symptoms, function, and quality of life? And then finally, Harlan's been a pioneer in this, as has the entire core team, all this effort to define the quality of care. And yet, a lot of those are based on process measures, but what ultimately defines whether or not we're doing a great job managing our patients? How well are their symptoms controlled? And so we leveraged a 5,000 patient outpatient registry to try and understand how is the variability in the control of patients' health status. And so we defined a good health status outcome as having a KCCQ greater than or equal to 75. We adjusted for 28 characteristics, and we looked at the median odds ratio across these 100 practices. And what you see is there are some practices where none of their patients had a KCCQ greater than 75, and others where almost 80% did. That means that there's a 70% greater likelihood that a patient going to one random clinic versus another would have good to excellent health status with a KCCQ score greater than 75 at one of the practices than the other. That variability is extraordinary. And that's why ICHOM and others are starting to endorse PROs as a measure of healthcare quality. So what is the final frontier? If PROs can increase the accuracy and efficiency of care, if they can risk stratify prognosis and treatment benefit, they can monitor response to therapy, and may even eventually become a requirement for quality measurement if CMS ever gets back into that space. They're integrating them into routine care has to be done. And how do you do that? So, it turns out from the patient perspective, and Joe Stellick at Utah had an AHA grant to try and do this. Patients actually really like this. So these detailed qualitative surveys of patients where the KCCQ was used in routine care. 23 of the 24 thought that it gave the providers a better sense of how they were doing. 16 thought it helped support doctor-patient communication. Almost all of them felt it improved their care, but 17, 2/3 of them felt more attention in the clinic visit should have been given to their KCCQ scores. I mean, this is what the patients are saying. In fact, to me, I think my interpretation is patients thought this was really important, really helpful, particularly if the doctors used them in their visit. Now, what about from the provider side? So this is, again, Alex Sandhu's work where he implemented this, and this is what the interviews of the nurse practitioners and heart failure and general cardiologists in that clinic reported. So the key thing was an engaged clinical champion. This is a quote, implementation lead. So Alex was very hands-on with the project. It wasn't like, okay, we're going to do this and here you go. He was very passionate, and he was always providing himself as available resource, checking in, emails. He was there throughout the entire thing. I mean, this idea of having somebody really help doctors understand, because none of you really know how to interpret this, right? I mean, for me, it's easy. I've been spending 30 years looking at it, but to know the difference intuitively between a KCCQ of 40 versus 80 is not something you necessarily have. And, you know, that's why the doctor said experience is key. So a clinical champion gets you to think about it. But then, yeah, I was going to say, obviously, the more you use it, the more comfortable you get, and the better you understand what each individual score means, because you've been in more and more positions where you've seen a score in that range, or you've seen a score and heard a similar story. It's an intuitive thing that happens over time. Integration into workflow is obviously very important and a big challenge. Um, but the doctors also thought it improved care. So that was the insight on how it should be implemented. But they said, you know, some of the things I said, you know, it's a standardized history. I think it's very helpful because, like I said, I think that my history taking it be a little bit variable from how the APP takes it or from how someone else does it. But I think the nice thing about the PRO is it standardizes that to a larger extent. You know, it engages patient communication. You know, here's a doctor talking about how seeing the scores allows him to really focus on changes or what the patient's really complaining about. And, you know, I shared that data, by the way. This is a disclosure, but, you know, I shared that data on the under recognition of angina, you know, and it implies that the doctors are clods, right? That they just aren't taking a good history. That may be the case, but the very first person to implement the KCQ was a guy named Charlie Porter. And this was back in 1995 or 6. And we had Scantrons, little bubble things you filled out. And so, you know, he couldn't score it until it went through the scanner, but he would describe what he called a shift to the left, right? So he'd look at the card and, you know, the worst scores are on the left, the better scores are on the right. And he would see that patients had a lot to the left. And so he walks into to see this nice elderly woman. He says, you know, how you doing, Miss Jones? And she says, oh, I'm doing great, Dr. Porter. Oh, really? Any shortness of breath? Oh, no, Dr. Porter. She says, any difficulty climbing a flight of stairs? Oh, no. You know, Miss Jones, you tell me that, but you filled out this questionnaire and it says that you're having shortness of breath a couple times a day. She goes, well, yeah, I guess that's true. And it says you're having a lot of difficulty climbing a source. Oh, yeah, I've been taking the elevator. He says, well, why didn't you just tell me you're doing so well and you had no shortness of breath or limitations? Oh, Dr. Porter, you're such a good doctor, and I didn't want you to feel bad. So, you know, it isn't, I mean, you know, I'm always willing to throw our profession on the bus, but that may not be the issue at all, you know? So this idea of better patient communication could go both directions, right? And then engaging patients in additional therapy, you know, and I'm not, you know, this is a doctor who, you know, maybe really wanted to get the patient to get our CRT. And so he used the poor KCCQ to talk about where he thought they could get them on the scores. And so, you know, when you think about implementing this, you know, identify a champion who will really support educating our colleagues in how to understand and use these and create some accountability so that it's actually done. Defining the mechanisms of how you're going to collect it. Is it through the patient portal? Is it through text messages? Is it through tablets in clinic? Figuring out how you want to present the data, you know, graphs over time, tables, et cetera. There's a lot of variations in this. And are we going to start sharing it with patients? What could the patient look at it on the patient portals? I mean, the first time this was implemented at St. Luke's, I was flabbergasted. The patients were so eager to see their scores. Like that was, you know, when they first did it, like I'm dying to see what my score was like. And I thought, like, why would they care? Because don't they know how they're feeling? And it turns out patients, I mean, just like your patients with HFrEF want to get another echo. Maybe they're feeling better, their EF's better. They want that reassurance. It's valuable to them. And so we need to think about, I don't know how you present to patients. And then figuring out how this is operationally in the EMR. I mean, I think it ought to be on the vitals page, you know, but others will feel differently. Sorting out these mechanics and figuring it out is tough work, slow going, likely to vary by practice and setting. But to me, I think it's all exciting. And so being as corny as I was when I opened, I want to end with just saying, you know, I think what we really need to do is challenge ourselves to think about what a sensitive, reproducible assessment of our patient's health status could afford us in systematically designing and creating a strategy to deliver higher value, more patient-centered care. Thank you so much, and I'd love to take any questions.
on, maybe I'll kick it off with this really brilliant talk, and I love the.
Oh, we'll stop there. That's good. Thanks. Thanks.
How did you implement it at your center? I mean, I can see this going into Epic. So as we screen the patients, take vital signs, do the EKG, they could quickly, or that when they're waiting in the waiting room, right?
Yeah, so
And-
I think the way we're going to try it, so we are implementing it. So interestingly, it was up and running at the Mid-America Heart Institute. And then we moved from next gen to Epic. And that was 8, 9, 10 years ago, and it got taken out. This year, after seeing this talk, frankly, the cardiologists get to negotiate with the hospital on certain activities that represent their quality bonus. And they said this year, implementing this in heart failure, the KCQ in heart failure was going to be one of the quality bonuses. So the movement that's happening now to get it back up in Epic is exciting. And the strategy is going to be to reach out to them through the patient portal. If they don't fill it out, when they come in, Epic has this kiosk mode. I work at the county hospital, so I'm on a Cerner system, but they have this kiosk mode. So they're going to have them fill it out while they're waiting. And then they're still figuring out exactly where in the EMR, but I think it's going to be on the sort of the loading page for the clinic visit for the heart failure clinics, along with the BMPs and the echoes and all of that. And so that's how we're planning to do it.
Can I ask you another quick question? You talked about ischemia, and we know the outcomes, there were no differences, but you're showing differences in KCCQ. Why do you think that we didn't follow patients? Do you think it's longer
Well,
follow-up? What do you think is
yeah,
going on
the
behind
ischemia was
it?
only the Seattle answer question. I'm sorry, I kept
Oh,
flip-flopping
right.
between
Yeah,
the two.
yeah.
So it was only the SAC. We didn't collect the KCCQ and ischemia. I hope that, Stitch 3 or whatever it is going to collect it, but we'll see.
We'll talk to you about that.
So I'm going to follow up a little bit on the same idea. So I've been in practice for 4 years, and I'm a heart failure cardiologist. And when I first started practice, I really wanted to make use of the KCCQ in my clinic. So I had all of my patients. I printed out the PDF, made multiple copies, gave them to patients, and would kind of just score it by hand. But I wasn't quite sure what to do with it, and part of it was because there is. In the advanced training statement for heart failure fellows, it does state that, when you're in your heart failure fellowship training, you're supposed to learn how to, utilize the KCCQ for patient care in regards to prognostication, understanding disease trajectory and things like that. But I never really was taught that. So I was trying to do it on my own, but I kind of was like lost in knowing how to really apply it. So I guess my question to you is, since it's obviously such a great tool, you've obviously talked about that, but how's the best way to kind of take this then to train, trainees, whether that be general cardiology trainees or heart failure fellows, how to really use this tool, understand how it's supposed to be used, so that we can use it to guide our clinical care?
So first of all, I had never heard that actually the statement recommended that people learn how to use the KCQ. Like, that's amazing to me. And so I'm very excited to hear that. I mean, I don't know how we train people to read the EKG, to learn. I mean, every new technology requires sort of training, and people train each other. And, we just haven't used it. A lot of the barrier and the resistance to this was, I think, that doctors felt like, my job is to take history. I already take a great history. I've given you a lot of dramatic examples where they don't. But the truth is that, we created a tool that nobody really felt they had a need for. And so it didn't get embraced or adopted very well, because it didn't seem like it was really adding anything over what we already have. And, this talk actually represents a lot of thinking about how would you actually teach somebody, or how might you be able to do it. And a lot of the techniques, I mean, how we really present the data to patients, nobody's done. I mean, your fellows ought to take that on as a project. You've got a T32 in implementation science, have a couple of them work on implementing the KCCQ, not only from the clinicians, and I think Alex Sandu giving a talk and sharing his approaches to how he trained his docs, who even after somebody as strong as that had tremendous variability in the way they actually used it. But, having your T32 fellows figure out, how do we share it with patients? And how does that have to be done by the provider? Could it be done by the MA? Could it be, I mean, this is such an exciting opportunity to forge a whole new way of thinking about leveraging a very unique, prognostically important, relevant outcome in of its own right data element. And so, to me, I'm energized by figuring out what we don't know and think that each of these examples I give are slightly different ways that you can start to leverage this, and to think about that in small nuggets so we can figure that out before we go to the next one, before we go to the next one. And the one I'd probably focus on if I were doing it first would probably be the routine use of clinical care, because everything else follows. I mean, once this is being done a lot, then you have in your EMR the health status of all these patients from which you do population health strategies, comparative effectiveness research, whatever. And I do think that, it doesn't sound like it exists at Yale. It's not really in Kansas City, but there are tremendous pressures on payers to shift the risk of Medicare Advantage to providers. And so providers now have a unique incentive to not just do more to get paid more, but if they do less and it's aligned with what the patients want, then they make a lot more profit. And so the other thing I would really think about doing is seeing if I could develop a group of sort of cardiac, geriatrically oriented providers who would selectively take the MA patients. It could do things like the shared decision-making tool, and start to, from ischemia, to start to, look, if the patient's going to benefit and wants it, by all means, let's do it. But if they don't want it, and it subjects them to peri-procedural risk, and it's going to cost the hospital money because they're going to make less from that shared risk Medicare Advantage arrangement they have with the payer, why are we doing it? And so, I'm jumping off, but the first thing I would do would be working on the clinical implementation model. And then your fellows who are rotating for clinic will actually start learning it. And you'll be, I mean, you had the disadvantage of having a hand score, but if it was automatically available, you must have started to get a sense of what intuitively scores of 20/80 meant. And that you would share with your fellows would absorb that, then they would share it with their colleagues and start using it. And that's how I think it will ultimately get taught and used. And, hopefully this will inspire people to start thinking about tackling that.
Jeff said, maybe when you're doing that, let me ask a quick question. And it's prefaced by saying this is the continuation of our earlier discussion. So you didn't speak to the stability of the patient as relates to when these scores can be most effective. And I challenged you, telling you while I've always used KCCQ in many, in pretty much every trial I've been involved in, and I've found it valuable, I've had less success when we were using them in acute in acute situations when patients may be changing rapidly during a hospitalization or an acute heart failure, where it seemed like those PROs were less, were maybe less effective. Can you speak to the stability of the patient?
So the KCCQ has a 2-week recall period. And, the FDA never liked that. They wanted to know how they're doing now. But if you talk to patients, right? I mean, how are you doing? Well, the last couple of days I've been great, but last week I couldn't get out of bed, so we wanted to capture a period of time to understand how they were doing. And we felt that for angina, because angina is more episodic, it was 4 weeks. And for heart failure, it was 2 weeks. And it turns out when you look at the 4-week recall period for the SAC, it is spot on with the median daily diary reports when they fill it out every day. The acute heart failure situation is you can't use a KCCQ day to day, and but it works very well because usually before they show up to the ER, they've been doing worse. So usually their hospital heart failure score is quite low, and then 30 days later, it's much higher. And things like epagliflozin, will make it even higher than placebo in Impulse trial. But, so I wouldn't think that in acute hospitalization it could work, which is why they went to these sort of 10-point Likert scales. How short of breath are you? There is some very provocative work that a woman named Corey Saucer did about 15, 20 years ago. And she was an ED doc. And so she gave the KCCQ when the patient showed up in the ED. They gave it at discharge or 7 days. And then they gave it at 30 days. And what they looked at is the change over these periods. So I would not have thought that the KCCQ would work well in the hospitalization. But what they found, and this is like 50 patients, like it's a small study, but it gave us a good insight. So it turns out that from admission on average to discharge, people go up by about 7 points on the KCCQ, and they go up about another 12 points over the next, out to 30 days. The most interesting thing was the mean difference was about 7 points in the patients who were not readmitted, but in the patients who were readmitted, there was no change. The baseline and the discharge were the same. And to me, that made so much sense because there are patients who they've been in the hospital for a while. You can't get them any better. You're tired of seeing them. They don't want to be in the hospital anymore. They just demand to go home. You say, fine, go home. And of course they come back in 30 days. They're not any better, So it was the company line is that it is insensitive for these acute changes. Some of this work, which I've never seen repeated, was very provocative in wondering, or could you create an acute version, so, they get the 2-week, the standard at baseline, but there's over the last 3 days short version that could capture some of the change. There's lots of work to do. It's an early stage, but.
So good to have you back in New Haven. A lot of people have referred to this as an assay, right? Which I think is a very good analogy for patient-reported outcomes. And I know I've heard you before say it should be reimbursed like any other lab test, something that takes resources to perform, expertise to interpret and integrate into care. And to me, that seems like the only way that we're ever going to move forward with patient-reported outcomes routinely used in clinical practice. What are the barriers to you? I mean, I haven't talked to you about this for a few years, but is there anything closer? Is having FDA approval of these assays getting us in that direction? Or what will it take? Aside from people
Look,
doing it
nothing would change the adoption of KCCQ than if the system got paid $5 for it, right? I mean, and there's a real expense. I mean, there's programming it, there's getting it, there's understanding the interpretation, et cetera. And it turns out that the politics, and there's already CPT codes for it, but getting a reimbursement for that is very difficult. The ACC has a committee that does that, and they're trying to figure out how to sort of frame that as an activity because you get paid for work done. And, it's just, I've never gone that direction, but nothing would change the adoption of these kinds of PROs and the acceleration of the patient centers of care, that finding a way to have hospitals reimburse. The only hospitals that are going to pay to build the IT infrastructures where there's a very strong clinical champion essentially demanding it. But the day that was opened up as an opportunity to get reimbursed for, every hospital in the country would do it instantly. I mean, I just can't imagine. And I think it would help. And I think that CMS would save money in the end, and the payers would save money in the end if you could really do it. And, think about how easy it would be to get rid of pre-authorization for PCI for stable coronary disease. Because if you had this data, as part of the evaluation, the Medicare could, or not Medicare, but the Blue Cross Blue Shield could see that the patient has a SAC score of 40. Why waste your time and their time getting pre-authorization, But if the SAC score is 100, maybe those they want to pre-authorize. Those are the kinds of things that would make so much sense. But every device, every drug company, every diagnostic test is bombarding the payers for codes and payment. And nobody's advocating for the PROs, and so they're not getting paid. And, I don't know how to overcome that. But I think it has a lot more value, as you talk about here, than almost every other thing. I mean, how much do we pay for a BNP and heart failure? $60? I mean, is that giving a lot more value than this? I mean, there are times where it does, but just the routine measurement of it, I doubt it. 12 times in a hospital stay, I doubt it, but we pay for it every time.
What thoughts are PROs for the Walmart condition, given that like this average model, like a statement by the if there is no PRO in the state?
So I'm not sure I totally understand the question. Is there a relevance to PROs, or do you think that they're crazy to have approved the TriClip because it worsened death, it worsened hospitalization, but improved the KCCQ? Which angle do you want me to take?
Mostly the second one.
So, it's interesting. I don't have a problem with it at all. And a lot of people want to argue that, it's an open label trial. I mean, you guys had Rasha here last week, and she'd say like, probably held that out as the prototypical example of, and I wish I could debate with her why in the world there was equipoise for the Orbit 2. Whoever thought that revascularization did improve angina? Like that was so we're going to take people off all their anti-angina medicines, blind them, and see if they actually got better. I mean, I didn't understand it, but that's me. Look, the patients, really felt better. There's decent physiologic.
We love Raj.
I love her. I mean, look, she's been a pioneer. I mean, there's nothing negative. That was not my favorite. Orbit 1 was amazing, right? So the issue is, and please, I'm not interpreting that as throwing it in the bus, but I'm just saying that to throw away a trial like Triluminate because it was open label, I don't think is quite right or quite fair. And I would, not that it couldn't have been done blinded, that would have been great, but it wasn't. And people have looked, so, it does look like there's quite a proportionality between the reduction in TR and the improvement in KCCQ. And if it was a complete placebo effect, you would expect that association. And, David Cohen and Suzanne Arnold tried hard to quantify the placebo effect by looking at the change in TR with change in KCCQ scores and adjusting, seeing if there was an interaction between placebo and treatment, and they didn't find one. But they just didn't believe it. They said there's got to be a placebo effect, even though we could measure it, and so they didn't. That data is buried and not really apparent. I think that when you ask patients, like, how are you doing since you last entered the trial? Are you doing much better or much worse than when you entered the trial? That's the kind of question that's very susceptible to a placebo effect, right? Everybody in the open label trials, I feel much better. I'm so glad you cracked my chest in this bypass surgery trial. But if you ask them in a very concrete way, over the last 2 weeks, how often had you had, shortness of breath? How difficult has it been to climb up a flight of stairs? I mean, I don't think that's as subject to a placebo effect as, we all presume it is because of the source of the data is a patient rather than a machine. Now, there's measurement error. I 1,000% agree. And, when you look at the noise in individual patients, I mean, they do flip-flop all over the place. I mean, and I don't want to oversell this. A lot of the data I showed you was means. You didn't see the actual spreads. They can be dramatic, but everything we do has noise, and I just think that there is a tremendous bias against PROs because they come from patients, and that's not fair. And I do think that, that has precluded us valuing and using them. And I think that's to the disadvantage of us as a profession, to our responsibility to society to be a judicious steward of its resources, and most importantly to patients themselves by not getting as accurate an assessment of how they're actually doing so that we can intensify therapy when needed and not over-intensify therapy in those who are doing well.
John, I think I'm going to stop it here and really thank you for this tremendous talk you gave us and inspiring us to try to integrate this information in different ways into what we do. There's so much more that we have to learn, but thanks to you, we've gotten this far, and I think hopefully you've given us some ideas of how to go the next mile. So thanks.
Thank you very much.